And we're going to start up with our first speaker of the morning. Please give a warm welcome to Dr. David Brownstein. David Brownstein is a medical doctor, board-certified family physician who utilizes the best of conventional and alternative therapies. He's the medical director for the Center for Holistic Medicine in West Bloomfield, Michigan. He's a graduate of the University of Michigan and Wayne State University School of Medicine. He's a member of the American Academy of Family Physicians and the American College for the Advancement in Medicine. He has lectured internationally about his successes using natural items. Dr. Brownstein has authored more than 10 books. Please give a warm welcome to Dr. Brownstein. Here. There was two up there.
Well, thank you all for getting up. Thank you all for getting up this morning. And I've decided after going to the party last night, I'm going back to dental school. That was a very nice house. So my disclaimer, I do not have any financial interest of a product in my talk or with any companies offering grant monies for this continuing dental and medical education program. So we're going to talk about statin drugs today. Let me play you a little song that most of us will remember. So unfortunately, that's what most of America wants these days, but I only want a few things in life, and I'd like a victory for my football team today. And so far, the University of Michigan is 1-0 this year. We have played one game, not two, and I'm told we played two, but I think I must have a 10-hour memory lapse from last weekend. I did not drive 3 hours to a game. I did not sit there 4 hours and drive 3 hours home. I don't know what happened in those 10 hours, but we're 1-0 as far as I care. And let me give you my prediction for today's game. So if you're betting, there's my prediction for today's game. So let's move on to the second topic for today, which is statin drugs. Sorry. So George Eel said, doubt is the beginning, not the end of wisdom. Most of us in our professional schools learn things that we don't think is true today, and that's why we're here at this meeting. And I'd certainly like to thank Rich Fisher for asking me to speak and putting on this meeting. And I've been to enough conferences out there. You guys have, I think, the best one, if not one of the best ones out there. And you should be thanking Rich Fisher for putting on this meeting, because he really does a good job with this. I called my partner at one of the breaks yesterday and I said, Rick, you got to come to this meeting next year. This is better than any of the other meetings that we go to. I don't know why I keep floating back to this. Oh, down. Down is the way I want to go. Okay, so we spend the most money in healthcare of any country in the world, and we don't get our bang for our buck. We buy more drugs than anyone else in the world. We certainly are not getting our bang for our buck. Right now we rank 37th in healthcare, the last amongst every wealthy Western country, and we spend the most of our GNP for that privilege. Our life expectancy stinks. Here it is for men and women. We are just not getting our bang for our buck, and we're taking too many drugs that don't treat the underlying cause of the problems that we're having and just treat the symptoms. This was a quote from a vice president of GlaxoSmithKline after he retired, and he said the vast majority of drugs, more than 90%, only work in 30 to 50% of people. Well, I think he's being generous with 30 to 50% of people, but I would agree with him. The vast majority of the drugs don't work, and I'll show you why. One of the reasons is they cause adverse drug reactions. And an adverse drug reaction is any noxious, unintended, and undesired side effect of a drug used in humans in therapeutic doses. What that means is the drug was taken appropriately, given appropriately, yet something happened that couldn't be predicted. And there was a study in 1994 where they looked at 6 major medical centers across the U.S. and the hospitalized patients in those centers during that year and what they died from. And what they reported was that there were 2.2 million adverse drug reactions of those. They extrapolated the numbers out nationally. They reported over 2.2 million adverse drug reactions resulted in over 106,000 deaths. Now, 106,000 deaths is a jumbo jet full of hospitalized patients not dying from their illness. They're dying from the drug that they took while in the hospital. They had an adverse drug reaction that couldn't be predicted. Now, that's 1994. We were using a lot less drugs then than we're using now. I say this study is an indictment on the failure and a warning of the toxicity of most of the drug therapies that are out there. And let me tell you, I was a conventionally trained doctor. I bought the party line when I graduated from medical school and in residency. And I'll tell you about my turning point as we go through this talk. But my turning point came when I realized these drugs were not working as they were advertised to me. So this is why I wrote the book, Drugs That Don't Work and Natural Therapies That Do. It's in a new edition right now. And my wife is my first editor of the book. And when she was reading this book the first time, she kept saying, "You're repeating yourself too much." And I said, "What am I repeating?" She says, "You're repeating this line." And the line was, you can't poison a crucial enzyme or block an important receptor for the long term and expect a good result. And I said, well, I'm repeating the line for a reason because it's true. And I wrote different chapters for different classes of drugs like osteoporosis drugs and gastrointestinal drugs, anti-inflammatory drugs, antidepressant drugs, and statin drugs was the 2 longest chapters of the book. And I'll repeat this line to you a few times during the lecture because it's true. I say you can't poison crucial enzymes or block important receptors for the long term and expect a good result. So we'll take a journey today. We'll see some scary things. Some of you might be taking statin medications and afraid to stop them. But really, once you pull that curtain aside, you'll see things aren't quite as scary as what you're led to believe. So, new statin guidelines were just introduced the end of last year. And currently, 1 in 4 U.S. adults are prescribed a statin drug. The new guidelines now focus on risk factors instead of cholesterol levels. Because for the last 30 to 40 years, they told us high cholesterol levels cause heart disease, which was a total lie. Those of us that could decipher the studies knew it was a lie. So now they've switched to risk factors. Of course, the risk factors are still what is your cholesterol level when you plug it into the calculator. But if we follow their new recommendations, it would increase the number of people on statins by at least 13 million in the U.S. And most of the increase was in people who don't have heart disease. So this would be for primary prevention, even though there's not one single study that gives an indication for statin drugs for primary prevention. This would, if we follow their recommendations, 1 in 2 people from the age of 40 to 75 would be on statin drugs. Now, the lead author of the article said that if you are a 60 to 75-year-old man and not on one, you should go get one, and every other woman of this age should get one. Well, I don't know. He makes this statement, and this is what I feel like. Now, who are these 2 gentlemen? Or what movie are these 2 gentlemen in? The greatest movie ever created in the history of mankind, The Big Lebowski. What are their names? What? Come on, what's the big guy's name? Walter Sobchak. What's his name? Donnie. Well, Walter and Donnie just heard that quote from that guy, and that's the look they have on their face, because Walter and Donnie know the research behind statin drugs and know it's a farce. And hopefully you'll have that look on your face next time you hear a quote like that from those guys. So, I called it, in the book I write about the myths of all these drugs, and myth 1 was, if you have cholesterol, you have heart disease. John Adams said facts are stubborn things, and whatever may be our wishes, our inclinations, or the dictates of our passions, they cannot alter the state of facts and evidence. So, let's look at the facts and evidence that cholesterol equals heart disease. This is from the peer-reviewed literature. High total cholesterol is not positively associated with high coronary heart disease mortality rates among the general population more than 40 to 50 years of age. More importantly, higher total cholesterol levels are associated with lower cancer and all-cause mortality rates among those populations. It's a documented fact that as many adults experience a mortal heart attack with a total cholesterol count under 200 as over 300. Half of patients who are admitted to hospitals for a heart attack have normal cholesterol levels. Now, they say they're not focusing on cholesterol levels anymore. They're lying, because if you go to that cholesterol risk calculator, the first thing you put in is your cholesterol levels. And I fooled around with those numbers a little bit. At my cholesterol levels of 220 and my age, I have a 5% risk factor for having a heart attack in the next 10 years at 51 years old. If I go up to 61 years old, I now have a 17% chance and I should be on a statin drug. And that's just nonsense. So the problem becomes if you don't understand how to read medical studies, then you're just going to follow the headlines or the print ads like this one where it says, in patients with multiple risk factors for heart disease, Lipitor reduces the risk of heart attack by 36%. So if you don't understand how they're coming up with these numbers, you might as well just read this ad that was in every print medium and was on TV, promoting Lipitor for heart disease. And then you have no clue on whether, it's true or not. Every medical student and resident that comes in my office, the first thing they get from me is an article, and I say, tell me what's the absolute risk, relative risk, and number needed to treat from this, it was a vaccine, from this vaccine that they're giving, and tell me if it's true or not. And none of them know how to do it off the bat. They have to go home, they figure it out through using the little calculations, and then I can show them how to do it in about 5 minutes. So I'll show you guys how to do it too. Now, let's look a little closer at this ad because there's a little asterisk there. And there's also smaller font there. And the smaller font says if you have high risk factors such as family history, high blood pressure, age, so if you have an age, I guess you have a risk factor, or low HDL or smoking. But let's follow the asterisk. So if you look at the asterisk, you got much smaller font, which I blew up, and it says that means in a large clinical study, 3% of patients taking a sugar pill or placebo had a heart attack, compared to 2% of patients taking Lipitor. So how did they come up with 36%? We'll figure that out. Well, it's really, the ad should have said 1% risk reduction for taking Lipitor for 3.3 years of use, which was the length of the study. And I'll show you how all these numbers come out. And I'll title this part of the lecture, How Do You Prevent Medical Errors? You better understand statistics, and if you don't understand that, you better understand damn statistics because they're fooling all of us with this stuff. So you're probably thinking right now what this gentleman's thinking, I haven't had statistics since dental school, what am I going to do? I don't remember this stuff, and golly, how am I going to do it? I'll show you how to do it. It's not hard. Relative risk. That's what they're reporting in all these studies. That's what they're reporting in the ads. That's what they report in that Lipitor ad. It was a relative risk of 36% reduction in heart attacks from taking that drug for 3.3 years. The relative risk is just a ratio of the treatment group over the control group. So for example, if a control group improved 1% on a placebo, treatment group improved 2% on a drug therapy, the relative risk is 2. The media would shout 200% improvement with this drug. Now, absolute risk is a more important number than relative risk. The absolute differences in risk are more clinically important than relative reductions in risk in deciding whether to recommend drug therapy from the New England Journal of Medicine. So how do you figure out the absolute risk? You just subtract the numbers, the final percentage numbers between the two groups. It's the absolute measure of the difference in risk between the two groups. For example, let's say our study was a 3-year study. Control group improved 1%, the treatment group improved 2%. The absolute risk difference is 1%. That's a more clinically relevant number for that patient sitting in front of you deciding whether they're going to take that drug therapy or not. So if we go back here, in a large clinical study, 3% taking the sugar pill or placebo had a heart attack compared to 2% in the treatment group. What's the absolute risk reduction? 1%. Well, how'd they come up with 36%? It's just the ratio. It's 2 over 3, which is 2/3. Subtract 1, you get 1/3. That's how they come up with that relative risk. That's a meaningless number for that patient sitting in front of you. Now, the questions are starting to come out about statin drugs, that they're not as advertised. And the real questions will come out if people can understand these statistics. Because the most important statistic in a drug study is the number needed to treat. That means how many people have to take this drug or this vaccine to prevent one illness or improve one disease state. So the number needed to treat is a useful way of looking at results or reviews of trials because it more usefully expresses the therapeutic effect that is needed to get a therapeutic result. The number needed to treat should help us make the choice that is right for an individual. For example, in H. pylori treatment, the FDA-approved triple antibiotic regimen, the number needed to treat is 1 to 4. What that means is 1 to 4 people treated with for every 1 to 4 people treated with this regimen, one person is cured. So another study showed the number needed to treat for a triple or dual therapy was 1.2. For every 1.2 people treated, 1 is cured. Those aren't bad odds. If someone has strep throat and you give them penicillin, out of 100 people treated, 99 are cured of strep throat. Those aren't bad odds. When we're talking 1 in 100 or 1 in 200 or 1 in 300, which is most of the statin studies, those are not good odds. So how do you get the number needed to treat? You put 1 over the absolute risk reduction. So in our case, remember it was 2% in the treatment group, 1% in the control group. The absolute risk reduction was 1%. 1 over 0.01 is 100. So in our study, 100 people would need to be treated for 3 years. That was the length of the study for one subject to get the benefit of the drug. That means 99 people took that drug without any benefit, paid their money, and were exposed to potential adverse effects. I say the study is a 99% failure rate. So for statins, they talk about primary prevention and secondary prevention. Primary prevention is you have not had a stroke or a heart attack. You're trying to prevent the first one. In low-risk patients older than 60 and taking a standard statin treatment, the number needed to treat to prevent vascular death ranges from 1,250 to 5,000. That means 1,249 to 4,999 took it without any benefit. That's a 99% failure rate for primary prevention. We're coming back here to our Lipitor study. 1% absolute risk reduction. What's going to be the number needed to treat? 1 over 0.01, which is 100. 100 people need to take Lipitor for 3.3 years to prevent 1 non-fatal heart attack, based on this study. That's what they're telling you we need to put 1 out of every 2 people in our country on statin drugs for. I say Lipitor, according to this study, was a 99% failure rate. Since 99% of people took it and didn't get any benefit, potential side effects, and had to pay their money for it. Now, the Jupiter study was a study that they claim gives them primary prevention benefit. That if you've never had a heart attack or a stroke, you should now take it because of these new guidelines. They're basing it on this Jupiter study. And I remember when the Jupiter study came out, it was headlines in the Wall Street Journal and the New York Times. I saw, because we get both of those papers, I saw those articles in the morning, and I usually don't get rattled, but I saw the headlines, I saw the quotes that were associated with the article, and I got rattled. And I'm eating breakfast, I'm thinking, oh my God, I got a book out that says the opposite. Maybe they finally got primary prevention status with this study. And they reported a 50% reduction in heart attacks and a 40% reduction in deaths. I mean, I'll give you the exact numbers coming up. And so I get to work that day, and I called the hospital where I have privileges, and I asked them to fax me the article. I get the article at lunch, I take my little calculator out, and I do my calculations, and I felt better. And I'll show you why. So, Jupiter, 17,000 healthy men and women. They had low LDLs. Although they had high CRP levels, so they had some inflammation going on, they were randomized to 20 milligrams of Crestor, which is a statin drug, versus placebo. Their endpoints were cardiovascular endpoints. The main purpose of this study was to prove statins have a place for primary prevention. Before this study, there was no place for statins in primary prevention. And these are what this study is what the new guidelines are based on. Now, I'm not going to read these quotes, New York Times, Wall Street Journal. Of course, these are the ones that threw me for my breakfast, but the New York Times said a large new study suggests that millions more people could benefit from taking the statin drugs, even if they have low cholesterol, because the drugs can significantly lower the risk of heart attacks, strokes, and death. But let's look at the study. They reported in the article that LDL declined by 50%, C-reactive protein declined by 37%, and the risk of MI was a 50% reduction. Of course, when I calculated the numbers out, the absolute risk was 0.41%. The number needed to treat was 244 to make those claims, meaning 244 people have to take statins for 1.9 years, the length of that study, to prevent 1 non-fatal heart attack. That means 243 people took it without benefit, paid their money, potential side effects. Again, another 99% failure rate that's reported as a positive study and totally changed the prescribing guidelines for cholesterol across the United States. Now, they also reported a 19% decline in deaths from any cause. However, when you calculate the numbers out, the absolute risk was 0.5% decline, and 1 over 0.5% is 200. Therefore, the failure to prevent death from any cause is 99.5%. These numbers are ludicrous. And the Crestor group was reported to have almost a 50% less MI as compared to the control group. Those were the numbers right there. So Crestor was 0.35%, control group 0.76%. How do you figure out these numbers? Go look at table 2 or 3 in any study. They'll tell you, here's the number of people that were studied in the control group. Here's who got the heart attack in this case. And then in the treatment group, it's the same thing. All you do is figure out the percentages. 0.35% to 0.76%. These are the numbers that they're changing all the guidelines on. When you subtract the numbers, you get 0.41%. And there's your number needed to treat. But those taking Crestor had 150% more fatal heart attacks. They obscured this data. And I saw when this was reported. It was reported in this chart right here. And they have Crestor versus placebo on top. And any heart attack and non-fatal heart attack reported on the other axis. So how do you find the number of deaths from fatal heart attacks and those that took Crestor? Those are the most important numbers. I want to know who's dying from this stuff. They don't report it here. And I saw this, and at my first glance at it, I missed it. And I was thinking to myself, why didn't they report who died? That's what they should be reporting in these studies. So how do you figure it out? Well, you just subtract the numbers. They hit it. Because if you look, any heart attack, non-fatal heart attack, how many fatal heart attacks? Just subtract the numbers. It's 9 on the Crestor side, and it's 6 on the placebo side. 6 divided, you just divide the numbers out. 29% on the Crestor side, 9% on the placebo side. Absolute risk reduction here is 20%. Therefore, what's the number need to harm in this case? 1 over 0.2, which is 5. So 5 patients need to take Crestor for 1.9 years for this study for 1 to die of a fatal heart attack. Them ain't good numbers. Of course, the media didn't report this. And once you sit down with this, I describe it in my book how to do this. You guys can figure this out as quick as I can. It's not that hard. Unfortunately, they teach us statistics in our respective schools that are ridiculous and unknowing, and we can't put it together into real life. But you can if you follow what I'm telling you here. Now, what they also didn't report when it first came out was that Crestor had more diabetes, significantly more diabetes than the control group. And they also didn't report that Crestor had 13 GI-related deaths compared to 1 in the control group. And Crestor had 18 reported confusional adverse events versus 4 in the placebo group. These are big numbers when you're talking that 250 people have to take it to prevent 1 non-fatal heart attack. Now, the results of this study being reported in the 3rd quarter of 2009, after when this article came out in the New York Times and Wall Street Journal and in the medical journal, the sales of Crestor rose over $1.15 billion as compared with the previous year. That's why they use those relative risk numbers. So, statins are shown to cause diabetes. A meta-analysis of 17 trials compared to placebo, 9% increased risk of diabetes in subjects who took a statin. Well, I thought diabetes caused heart disease. Meta-analysis of 13 trials, 91,000 subjects, 9% increased risk of diabetes for those who took statins. The Jupiter trial just showed you a 26% increased risk of developing diabetes over 1.9 years. Yet these aren't in the guidelines that they want you to follow now. Despite lowering LDL levels, statins have been shown to increase fasting insulin levels, decrease insulin sensitivity in a dose-dependent manner, increase fasting insulin and hemoglobin A1C without a significant change in glucose, and decrease adiponectin levels, which is an anti-proliferative and anti-angiogenic agent. Now, 2 years later, the Jupiter trial was reviewed, and an independent panel found the trial was flawed. 9 of 14 investigators had financial ties to the sponsor. The principal author had a conflict of interest with the CRP test. Every time somebody orders a CRP test, he gets a little money for it because he developed it. He was the principal author of this study. And they stopped the study early. It was supposed to be a 5-year study. They stopped it in 1.9 years. And that's going to make, if there's going to be any problems with the study, that's going to make it less obvious because they stopped it so early. And the authors of this independent review said the results of Jupiter do not support the use of statin treatment for primary prevention of cardiovascular disease and raises troubling questions concerning the role of commercial sponsors. Yet this study is the linchpin of the new cholesterol guidelines that are out there now. Now, in this article, I've highlighted here the concerns aren't expected to prompt doctors to stop prescribing statins. Doctors haven't stopped prescribing them. Doctors are prescribing them more. It's ludicrous to me. Now, how did all this start? This all started back in the early 20th century when Russian researcher Anishkov fed rabbits cholesterol. The rabbits developed atherosclerosis in their aorta, very similar to the way humans develop atherosclerosis. And he wrote an article that said cholesterol causes atherosclerosis. That's how it started, and it picked up steam in the 1950s when Ancel Keys did his 6-country study. His conclusion of the study that was lowering dietary fat will result in lowered mortality from heart disease. He made the cover of Time magazine. He made the cover of, what was that big one, Life magazine. He was testifying in front of Congress. He made all the radio shows at the time and the TV shows that were available. And here's what he reported in his famous graph that's still shown to all medical students today, that more calories you have from fat, the more cardiovascular deaths you have. And it's a linear correlation. Anytime you see a study with a linear correlation, that study should give you greater pause that there's a little more power behind that study. But what's not reported is when Ancel Keys had these 6-country study numbers available to him, he had more than 6 countries available to him. He just cherry-picked these to show that linear correlation. So he had 22 countries' data available to him. Here's the plots of the 22 country data. When you draw a linear regression line, there's no correlation. He just fudged the data. And that's what really took off, and that's when we became fixated on lowering cholesterol levels, lowering fat in our diet. And as a country, we did it. We lowered cholesterol, we lowered fat in our diet, and what's the consequence of that? We're suffering more obesity, diabetes, and heart disease than we know what to do with. George Mann said, the lipid hypothesis is the greatest scientific scam of all time. To be a dissenter is to be unfunded. He was a dissenter, he didn't believe it, and they unfunded him. He never could publish another article because he couldn't get research money. So, if cholesterol is not such a bad thing, what is it good for? It's a precursor to vitamin D production in the skin. It's necessary for fat and mineral absorption. It's an integral substance for all cells of the body. It forms a myelin sheath around the nerves and important for optimal functioning of serotonin receptors, and immune system functioning depends on cholesterol levels. And it's needed for all the adrenal hormones. All the adrenal and sex hormones are produced downstream from cholesterol. What do you think is going to happen when you mess with cholesterol chemically and lower it down to those hormone levels? That's how I got started in all this. It was 1992. I had finished residency, and I was 6 months out into practicing conventional medicine, not interested in any of this stuff. I was practicing the party line. I was unhappy. I started to feel unhappy about what I was doing, and for unknown reasons, I didn't understand it, but I recall vividly getting up for work one day. My wife's getting up, we're getting ready to go to work, and I blurt out to her, I don't want to be a doctor anymore. Now, her first comment, that was between her and I, because I had $90,000 in loans. That's all I wanted to do my whole life. I'm 6 months into it, and I say, I can't do this for the next 30 or 40 years. Her second comment was, what are you going to do about it? And I really didn't know at that point. What was throwing me off was people weren't getting better. I was prescribing all these drugs, and then I'd have to prescribe other drugs to treat the problems from the first drugs, and they weren't getting better, and I didn't feel like I was treating the underlying cause of their issues, and I had no idea what to do about it. Short part of this story is a chiropractor gave me a book called Healing with Nutrition by Jonathan Wright, and I opened that chapter, the chapter on heart disease. My father had his first heart attack at 40, his second heart attack at 42. Over the next 25 years, he developed continual angina. He had bypass surgeries and angioplasties. He was on 12 different medications to control blood pressure, cholesterol, and diabetes. More importantly, at that time, he looked like he was going to die at any moment. Now, my dad never took care of himself. He smoked. He was overweight. He never ate well in his life, and certainly never exercised a day in his life. But so I read this book. I called my dad in the office the next day, and I drew 2 blood tests on him. I drew a thyroid level, and I drew a testosterone level. His testosterone level read as below detectable limits. His thyroid levels were in the reference range, but in the lower part of the reference range. So I put him on two things, natural thyroid hormone and natural testosterone. And within 7 days, his 20-year history of angina melted away, never to return. Within 30 days, checking his levels again, his cholesterol stuck in the 350s, fell below 200 without changing any of those bad habits. More importantly, he lost that gray pasty look on his face and pinked up and looked better and was doing things. And when I checked all these hormones on him, I found them all low. Pregnenolone, DHEA, progesterone, hydrocortisone, and I mentioned to you testosterone before. So once I got these things balanced in my dad, and the first thing was testosterone, his cholesterol level naturally fell to a normal range without changing any of his bad habits. So one of the theories that I have is that perhaps this pathway, this deranged pathway, because people are eating poorly, they don't have enough thyroid hormone, they don't have enough vitamin A, which is a cofactor for all this pathway. The body has to shove more substrate into that pathway to get it to work, yet it can't work. So cholesterol just goes up. The worst case in this scenario would be to do what? Block this down. That's not what should be done. What should be done is fix this. So I can tell you after 20 years of doing this, fixing this helps out a lot of people. And I don't need to block this down. Nobody should be blocking that down. All right. So conditions associated with an imbalanced hormonal system. There is a who's who. It's on here. It's in your notes. And there's more about this in my books. This was the first book that I wrote, and I really wrote it because of the experience I had with my dad. And I started using bioidentical hormones on every patient since then. And now every patient gets a hormonal nutritional workup when they walk in the door. So back to our original idea of statin drugs. Does lowering cholesterol protect against heart disease? Well, the American Heart Association, American Medical Association, the National Cholesterol Education Program, and everybody else out there says it does. They claim it's evidence-based medicine. I love when they take their evidence-based hammer out and they start trying to hammer us holistic guys. And they're not using any evidence-based medicine. They're using relative risk, which is not evidence-based at all. Now, according to AmericanHeart.org, they cite 5 major trials of statin drugs and say, know your blood cholesterol levels. If it's high, you can reduce your risk of heart disease by lowering it. Let's look at those 5 studies. Heart protection study was one. They looked at placebo versus Zocor, and these were all done in adults. And the most important number in these studies is who's alive at the end of the study and who's dead. That should be the most important number. I'm sure you guys would agree with me on that one. So in the mortality results, the placebo group had 85.4% survival after 5 years compared to 87.1% in Zocor. Subtract the two numbers, you get an absolute mortality decline of 1.7%. The second study they cite is Prosper, and it was Pravachol versus placebo. And 89.5% alive in the treatment group, 89.7% alive in the Pravachol group. I said that backwards, but you can see the numbers. Subtract the numbers, the absolute mortality was 0.2%. All had 84.7% of control group alive versus 85.1% of the treatment group. Just subtract the numbers, 0.4%. Ascot was the 4th study. This was the one with that ad with Jarvik that I showed you before with that 36% reduction. So we went through those numbers before, the 1% absolute risk reduction versus 36%. But in the mortality part of the study, 95.9% of the control group alive versus 96.4% of the Lipitor group, 0.465% decline. The 5th study they cite is Prove It. Now there was no placebo group here. It was Lipitor or Pravachol, which are both statin drugs. And there's the difference in the number of deaths between the two groups. But if we summarize these 5 evidence-based studies, no study showed a dramatic decrease in mortality in those that took a statin. In fact, statins have never been shown to decrease mortality in anyone who takes them. But there's an average of 0.775% decline in those that use statins in the 4 studies that used a control group. Nonsensical numbers. That's what they're basing the idea that 1 in 2 of us needs to take statin drugs on. I say you can't poison a crucial enzyme or block an important receptor for the long term and expect a good result. So what are the risks of lowering cholesterol levels? Well, there are many studies that show a higher death rate in the elderly who have lowered cholesterol levels. And elderly females who have cholesterol level below 155 associated with a 5.2-fold higher death rate as compared to women with a cholesterol level of 272. The elderly should not have a cholesterol level below about 160. There's clear associations in numerous studies across different cultures that death rate goes up when that cholesterol in the elderly drop below about 160. Women of all ages and men over 55 with high cholesterol have decreased mortality. And over 150,000 studied in Australia found that lowered cholesterol predicts premature death in men of all ages and in women over the age of 50. As compared with moderate cholesterol levels, 160 to 200, there's a 49% increase in mortality for cholesterol less than 160. For women, a 50% increased mortality. High cholesterol, those greater than 240, not a risk factor. When you're over the age of 60, your predictor of longevity is what's your cholesterol level. It's the best predictor you have. The higher it is, the longer you live. The lower it is, the shorter you're going to live. Now, the problem is, number one, we shouldn't be taking these drugs. Number two, these drugs cause a lot of problems. I keep having to lower the font to put more in here because I can't get all the adverse effects in here. Look at the first adverse effect on there, ALS. ALS has skyrocketed lately, and I have no doubt it's because of statin drugs. Statin drugs poison the mitochondria, they drop CoQ10 levels, they cause a mess on their hands, and people get these ALS or ALS-like syndromes going on, and I think it's directly related to statin use. Now, it's not totally related to statin use, but there's a direct correlation between statin drugs being used and this rise in ALS that's happened. So what say you, Mr. Gump? His mama always gave him good advice in that movie, and his mama says statins have too many side effects, so he wasn't going to use them. I suggest you take her advice in this. So great drug was a prolonged life? No. Never been shown to prolong life. Why are 1 in 2 of us being recommended to take these toxic drugs? So let's look at the biochemistry behind statin drugs. When I have medical students and residents come in, I always quiz them on the biochemistry of these drugs. Do you know how these drugs work? And, they're usually shaking their head no. And I said, if you don't know how they work, then how can you prescribe these drugs? So here's the pathway for cholesterol production. Cholesterol's here. All those hormones we looked at earlier are down in here. But here's the precursor to producing cholesterol. So statin drugs work by poisoning the enzyme HMG-CoA reductase. And everything downstream from that pathway, from that enzyme, drops. So you get lower cholesterol levels with statin drugs. That's how they work. But you also get lower CoQ10 levels. You get lower dolichol levels, lower mevalonate levels. All these have effects on the body. But let's look at CoQ10. And CoQ10 is inhibited in the HMG-CoA reductase pathway, and it's transported by LDL cholesterol particles, which gets lowered in statin drugs. So it's a double whammy against CoQ10 when you give statin drugs. So CoQ10 has been shown to prevent cancer, cardiac arrest. The statistics for CoQ10 match any statin drug out there. Just treat them with CoQ10 because you'll have the same relative risk percentage decline in death and cardiovascular disease as any statin drug out there, and you won't have the adverse effects. Congestive heart failure is rising at epidemic rates. I have no doubt it's because of statin drugs. I gave a statin talk in front of a group of academic cardiologists, which, by the way, was my last lecture to ever a conventional group of doctors in my life. And I was nervous, and I'm sweating, and I was really uncomfortable during the talk, and they were yelling and carrying on and standing up and interrupting me, and I kept saying to them, come up and show me on this pathway where I'm wrong. And I did a lot more biochemistry when I was talking to them about it, and no one would come up. They just kept saying, you're wrong. At the end of that lecture, I knew I wasn't wrong. They had nothing to say except you're wrong, and they don't understand how these things work. They're just focused on cholesterol numbers and now this new heart calculator. Diabetes is directly improved with CoQ10, hypertension, infertility, kidney failure, macular degeneration, migraine headaches, neurodegenerative disorders, Parkinson's, viral myocarditis. All these things improve with CoQ10, and interestingly, almost all these things are on the adverse effects for statin drugs. Now, statins cause skeletal muscle damage. This was a study with, I don't know why these don't make the headlines in the Wall Street Journal and the New York Times. 4 groups were studied, a control group with no statin use, former statin users with muscle pain, average of 3 months off statins. Third group was current statin users with muscle pain. Fourth group was current statin users without myopathy. What they found was damaged muscle fibers were not found in the control group, but they were found in all the other groups. And in former statin users with muscle pain were the same amount as the current statin users with muscle pain, about 60% of damaged muscle fibers. So if you think about it, I called the author of the study after it came out, and I asked him, could you send me pictures of the muscle fibers that you did? And he was nice enough to send them. This was a picture of somebody off the drug for 3 months, and their muscles were still falling apart. Can you imagine if they showed a study of someone taking vitamin C and their muscles were falling apart 3 months after they stopped taking vitamin C, how quick the FDA would be to remove that vitamin C from the marketplace? You couldn't even blink fast enough to do that. Heart failure is the most common reason Medicare patients are admitted to the hospital. It's occurring at epidemic rates, 550,000 new cases per year. The most important number is the bottom one. 50% of those with heart failure will die within 5 years of their diagnosis. 50% are dead within 5 years. Now, it's increasing at epidemic rates because of statin use. 14 patients who were given Lipitor, after 3 to 6 months, 71% developed diastolic dysfunction. And diastolic dysfunction is the major cause of congestive heart failure out there right now. Interestingly, my quote, you cannot poison a crucial enzyme and expect a good long-term result. I say statins will follow the same path as the COX-2 inhibitors, which were shown to cause heart attacks and blood clots in people. And of course, the only people saying the COX-2 inhibitors were going to cause heart attacks and blood clots were the holistic guys looking at the pathway where those COX-2 inhibitors worked and predicted people were going to get blood clots and strokes and heart attacks. But the same study showed 90% of the patients treated with 300 milligrams of CoQ10 improved their diastolic dysfunction, 4 completely reversed their diastolic dysfunction. Why isn't CoQ10 recommended for all statin users? I don't know, but it'd be better to just don't give them statins in the first place and perhaps give them CoQ10. Hospitalizations for heart failure surged by 230%. This 230% is not our aging population as this article describes. It says something else is going on out there that's causing heart failure to go up at such a rapid rate. No doubt about it, it's statins. 17,000 hospitalized patients for heart failure. They looked at the relationship between cholesterol levels and their death rate. And look at the death rate. It's a linear correlation that lower the death rate. I can't see it up there, but lower the death rate as you go from left to right, and the cholesterol rises from 3.3% in cholesterol less than 118 to 1.3% cholesterol greater than 180. Just remember, after the age of 59, your predictor of longevity is what's your cholesterol level. The higher it is, the longer you live. The lower it is, the shorter you'll live. In this study, they said low cholesterol levels are associated with poor prognosis in patients with heart failure. Statins cause poor brain function. The highest concentration of cholesterol in the body is in your brain. What do you think it's going to do when you poison the enzyme HMG-CoA reductase that's a precursor to making cholesterol? Median age of this study was 75. They found that higher cholesterol levels at age 65 and older was an independent predictor of an increased cognitive performance and a higher level of information processing over a 6-year period. I mean, you could almost say duh to this. What do you expect is going to happen? Thus, a total lower cholesterol level in the elderly population should be considered a frailty marker, predictive of worse cognitive functioning. Cancer, all the cholesterol medications, the older drugs and the newer drugs, have been associated with increased cancer rates. Breast cancer rates increased by 1,200% in statin users in the study I've cited here. And numerous animal studies have shown an increase in cancer rates associated with statins. Statins hinder the NK cells and other immune system functionings. Again, you could predict this is going to happen when you lower cholesterol levels or you poison HMG-CoA reductase. So statins also cause Parkinson's disease. Parkinson's increasing at epidemic rates. When I started off in medicine, you saw Parkinson's very infrequently. Now it ain't so infrequently. Compared to those with LDL of greater than 138, now they want our LDLs less than 70 now. LDL of 115 to 137, a 220% increase of Parkinson's. An LDL lower than that, a 350% increased risk of Parkinson's. And an LDL less than 92, which is really what they want us at, 260% increased risk of Parkinson's. Again, easily predicted of brain disorders, with statin drugs, Parkinson's and Alzheimer's disease. Here's a comparison of healthy controls, middle stages of Alzheimer's and late stages of Alzheimer's with cholesterol levels, and you can see a linear correlation with this as well. And the same thing with LDL levels. Same thing with triglyceride levels. So the problem with statins, and we saw it yesterday in some of the lectures, was mitochondrial damage. Electron microscopy of statin-treated muscle fibers showed mitochondrial damage is present even in fibers that appear otherwise unaffected. So think about that. Even in fibers that appear otherwise unaffected, there's mitochondrial damage. It's just a matter of time. And the older people get, the more damage this is going to cause. Now, you can't exercise when you have statins because you're going to increase more mitochondrial damage. The prevalence of myopathy dramatically rises to as high as 25% in statin users who exercise, and myopathy was shown to occur in over 75% of statin-treated athletes because they're stressing their muscles more than the rest of us. So perhaps with statin users, we should suggest they don't exercise. Really, that would be the right advice to give them. Statins induce apoptosis in the wrong cells. Cardiac cells, smooth muscle cells, myotubules, myoblasts, and differentiated human skeletal muscle cells. Statins cause memory loss and diabetes, as I mentioned before. Compared to cholesterol levels of 160 to 200, cholesterol at 160 a 49% increase in mortality in men, 50% increase in mortality in women. Cholesterol greater than 240, not a risk factor. There's a whole bunch of these studies that basically show the same thing. I'm just checking how much time I have left. And again, another linear correlation showing lower serum cholesterol levels, the higher cardiovascular death percent, and the higher stroke rate. This is an interesting graph that basically you can see here lower LDL and lower cholesterol levels associated with a dramatically increased 6-year mortality rate, for those who took Zocor. The Honolulu Heart Study. This should have made headlines across the world when this thing came out. It was a mean cholesterol of 3,572 Japanese American men aged 71 to 93 years old, and they found that the mean cholesterol fell significantly with increasing age. As we know, cholesterol levels generally decline as people hit their older ages. So they put it into 4 quartiles, the cholesterol levels, and they looked at the death rate. And you could see a direct linear correlation with a higher death rate with the lower cholesterol levels. Again, why would any elderly person, period, want to be put on a statin drug? I put this in the same category as putting mercury in somebody's mouth or injecting mercury in pregnant women as a flu vaccine. What did Forrest Gump say? Stupid is as stupid does. Only the group with the lowest cholesterol levels had a significant association with mortality. We have been unable to explain our results. These data cast doubt on the scientific justification for lowering cholesterol to very low concentrations, less than 180 milligrams per deciliter in elderly people. Now, they want the primary prevention recommendation because that's how they're going to get 1 and 2 of us to be on these drugs. Primary prevention, remember, is you have not had a stroke or heart attack. You're taking this to prevent your first stroke or heart attack, first cardiovascular event. And these from the peer-reviewed literature, statins do not have a proven net health benefit in primary prevention populations, and thus when used in that setting do not represent a good use of scarce health dollars. The claimed mortality benefit of statins for primary prevention is more likely a measure of bias than a real effect. It's totally a measure of bias. They don't have the indication for it. Secondary prevention. You've had a stroke, you've had a heart attack, you've had a cardiovascular event, you're trying to prevent another one. Now this is where statins have some benefit, but it's a minimal benefit. The number needed to treat in the best of the studies is 30 to 60, meaning 29 to 59 people have to take that drug to prevent one secondary cardiovascular event. Again, not good numbers. Still an 80 to 99% failure rate. I say, as Cora said in our old commercials, where's the beef behind these recommendations? There is no beef behind them. It's smoke and mirrors. It's like the Wizard of Oz when Toto has to pull the curtain aside and show him that the wizard is back there, and it's not so scary when you look behind the curtain. Now, what about statins and testosterone? That was one of the first hormones I treated my dad with. There's numerous studies showing testosterone helping prevent cardiovascular disease and treat cardiovascular disease if it's available. What do you think statins are going to do to cardiovascular disease? All you have to do is look at that pathway and realize what it's going to do. It's just studying biochemistry here. Statins lower testosterone levels. Well, of course they do. They block the enzyme that produces cholesterol, which is the precursor to the adrenal and sex hormones. You can predict this. So I would encourage you, when drugs come out and you're confronted with this either personally or professionally, look at the mechanism of action of these drugs and then decide if you think it's appropriate for the patient to use it. That's what I teach the medical students and residents who come through our office. Now, the benefits of statins. The benefits of statins are a slight decreased risk of preventing a non-fatal heart attack, about 1%. However, remember, this is secondary prevention. And it's probably independent of a cholesterol-lowering effect. Maybe it's an anti-inflammatory effect, although that's not, I don't believe that's the case either. But, I mean, we're only looking at a 1% reduction. I think it's a statistical manipulation of numbers. So if cholesterol levels are truly elevated, we should be asking the question, what's a way to treat this elevated level? Why is the level elevated in the first place? Statin drugs remind me of driving your car, the engine light comes on, pull the car over to the side of the road, pull the fuse for the engine light, and then go driving again. That's what they do. They poison the enzyme, they pull the fuse. It's the same thing. Let's figure out why the engine light's on in the first place. Well, maybe there's a hormonal imbalance. Maybe they don't have enough of those adrenal and sex hormones. All you got to do is get that pathway balanced. I saw it happen to my dad over 20 years ago. I see it happen on a daily basis in my practice. Maybe there's a toxicity going on. Maybe because some nice dentist who was in a movie that I saw the other night put mercury in someone's mouth and still defends putting mercury in someone's mouth, which is beyond me. And what's the body's response to a toxic item coming into the body? It raises cholesterol levels to protect the nerve tissue and the fat tissue of the body. What's the worst thing you want to do in that case? Drop cholesterol levels. Nutrient deficiencies, they don't have enough vitamin A, they can't make those sex hormones. And body's going to put more substrate into the pathway, more cholesterol. What's the worst thing you can do? Block cholesterol levels. They have a poor diet. They're going to become nutrient and hormonally deficient. Body starts to produce more cholesterol to protect the body in this case. Again, the worst case in this scenario is poison an enzyme that makes cholesterol. What if they have inflammation? Cholesterol is an anti-inflammatory agent. The body's trying to put out the fire with cholesterol. Why do you want to stop the firemen from doing their job? So if it's a hormonal balance, one of the things to consider is thyroid. I talked to you guys about thyroid a while ago. There's been known for over 100 years that low thyroid causes elevated cholesterol levels. It's too bad cardiologists don't check this out first before immediately just reflexively putting them on a statin drug. What about vitamin C, CoQ10, vitamin D, iodine, or hormonal balancing with bioidentical hormones? That's treating the underlying causes of perhaps an elevated cholesterol and searching for why it's an underlying cause. Vitamin C is a natural HMG-CoA reductase inhibitor. It doesn't poison the enzyme. It slows it down. It's been shown to reduce cholesterol levels. It reduces lipoprotein a, promotes the production of CoQ10, protects cholesterol and LDL cholesterol from oxidizing, and maybe they're vitamin C deficient and that's why their cholesterol levels are going up. Again, that's a more comprehensive way to treat a problem like this and to look at a problem like this. What about vitamin D? There's numerous studies that show direct correlation with low vitamin D levels and elevated risk of heart attack. In this study, lowest vitamin D had a 200% increased risk of heart attack versus those over 30. I've been checking vitamin D levels since 1992. I can assure you the vast majority of people are vitamin D deficient. But keep in mind that it's really important not to cause other problems in the body by prescribing a drug. And you prescribe a statin drug, you are going to mess with this whole pathway, and there's a whole bunch of consequences of that, from cancer to heart disease, chronic illness, autoimmune disorder, that result from that. So, Forrest, what say you? His mama says, try natural therapy instead of a statin if someone has an elevated cholesterol level. I couldn't agree more. I do not say that you should try red rice yeast. It works just like a statin drug does. I say statin drugs should be pulled from the market, and you might as well pull red rice yeast along with it. There's no reason to do that in any patient. A search needs to be underway why cholesterol levels are elevated if they're elevated. So, George Mann said the greatest scientific deception of our times is cholesterol equals heart disease. And Statin drugs are going to bankrupt our country. We're not getting our bang for our buck. We're making people sick with them, and I don't think anyone should be on them for any condition. I'll leave you with my final thoughts. You can't poison a crucial enzyme or block an important receptor for the long term and expect a good result. Galileo wrote to his friend Kepler from prison when they put him in prison because he said that the sun doesn't rotate around the earth rotates around the sun. And the church didn't like that, so they put him in prison. He wrote, "My dear Kepler, what do you say of the leading philosophers here to whom I've offered 1,000 times of my own accord to show my studies, but who, with the lazy obstinacy of a serpent who has eaten his fill, have never consented to look at the planets, moon, or telescope? Verily, just as serpents close their eyes, do men close their eyes to the light of the truth." Now, following my talk today is one of my heroes, Dr. Wakefield. I don't know if he's here yet. I've been following Dr. Wakefield since the 1990s when he came out with his groundbreaking study. I've been following what happened to him over the years and his it's not crucifixion, I don't want to use that word, but it's persecution, that's the word I want. I've been following his persecution, and he's finally going to be vindicated when the media finally picks up on the study. I've been blogging about this, so I'm looking forward to what he has to say, and I hope you all listen to his talk. But today we're all going to remember, let's go blue. Thank you guys very much. Just for the Ohio State people, you can hear the whole damn thing. I have some book flyers out back. If you guys want my books, I didn't bring them.